All right. Good morning, everyone. Good morning. My name is Elizabeth Falcone. I am Senator Warner's Chief of Staff. And I'm really thrilled that you're all here for our Women's Conference. We're really excited about this breakout session. We have Dr. Price with us, who is the CEO of the Williamsburg Regional Medical Center at Sentara, and a nurse midwife. And I will say, if I can, someone described her to me as a badass. So I am particularly excited to have you. So thank you so much, Dr. Price. Take it away.
Thank you. Nice to meet everybody. I know people will trickle in. I heard there's a line at the bathroom. I understand that. So I just don't let people trickle in as they come. So I'm a little curious. How many of you came to listen to this talk because you are concerned about healthcare disparities in the state? Yeah, majority of the audience. Okay. How many of you came because you personally have had experience in healthcare and this is something that you're really interested in? Okay. How many of you came for another reason? Okay, yeah, okay. Do you want to share? Me? Yeah, you said you came for another reason.
All of the above, but I'm a nurse midwife, and so I just love hearing about what you do.
Nurse midwives, and maybe in the wild they hug. Yes, thank you. Nice to meet you. Yes, there's not that many of us. No. And I should come to tell people.
Y'all are the best. Y'all are
the best. Yeah. So you're not going to meet many nurse midwives, so here's your chance to slice in a while. So I'm going to hit on all of those things today because I know these are the things that are in the forefront of women's minds right now. We live in a time where we're seeing a lot of stuff floating around on social media. Media's great, really scary headlines out there. But the reality is that we have to lead women's healthcare in this nation, and somebody has to figure out how to do that well, and how to listen, and how to figure out what those needs really are, and how we're going to address it. So I'm going to talk a bit about leadership today. Who is leading, how we're leading, what is happening in the landscape of women's health today, and then what in the future may be a better model, a better work, or a better today. Because I think we all know there are gaps in care. People are speaking up and telling us it's not working the way it's working today. So I'm going to talk through that, and then we'll leave some time for Q&A. All right. So women make 80% of healthcare decisions in the United States. They make them for themselves, they make them for their partners, their spouses, their children, often their parents or their elderly relatives. And so they are really, really, really important consumers. But if you look at procedures done annually that are very specific to women, look at the numbers. How many women engage in healthcare? That's on top of the stuff men get too, right? Like heart attacks and headaches, knees that need to be replaced, hips that need to be replaced, skin issues. On top of that, this is what's happening just in women's procedures in the United States. So every year, 6.6 million babies are born, right? Cesarean is the most common surgical procedure in the United States, with more than 1.2 million done every year. And DNC, which is where the uterus is bleeding, or another issue where we have to go in and work on that, is a close second. Well over 1 million DNCs performed annually. 600,000 hysterectomies, 25 million gynecology specialty visits, 27 million mammograms, 26 million pap smears, 630,000 abortions, 88,000 heart attacks, and 100,000 mastectomies annually. That's what women contribute to the healthcare system. So we're definitely engaging in the healthcare system, one part of it. But I think what I hear a lot with my speak is that people don't feel that the system is designed to deal with them. That you're just kind of going into someone else's house where you don't feel at home, you don't quite understand or speak your language. So we'll talk through how we plan to change that. Here's the other one that's heavily in the news, maternal mortality. These are national statistics. This is a slide that's actually coming from the National Center for Health Statistics. But if we look at the state of Virginia in particular, what we know is that maternal mortality is going up. The state of Virginia just released its triannual report. It takes us through the first year of COVID, and so we're learning what's going on in our state. In the state of Virginia, maternal mortality data is collected all the way through pregnancy, the birth process, and up to 365 days after that. So that entire postpartum year is included in that. So this is not just the birth experience that these statistics are about. About 20% of the Virginia population is Black, but they have a way higher risk of maternal mortality. 50% of maternal mortality in the state of Virginia is due to natural causes. So some healthcare thing that happens. What do you think the top reason out of those natural causes? Anybody tell me? It's heart disease. Number one reason for maternal mortality due to natural causes is chronic heart disease, pulmonary embolisms, cardiomyopathy. After that, we do see hemorrhage, we do see sepsis, but that is overwhelmingly the natural causes. Now, what does that mean? Does that mean you're having a baby and somebody got a heart attack? No, that's not what it means. It means that somebody shows up for the first prenatal visit at 22 years old, not really seeing the primary care doc because they felt fine. And here they are, maybe 3 months pregnant, and we take their blood pressure and it's still changed. And they did not know. And so for all these years, this blood pressure has been really doing some damage to their system because that's silent. You don't know you have that. And now you're pregnant. So can that trick you with every medicine and throw it away? So we have to be very careful. Now it's going to impact your pregnancy. It's going to impact your developing baby, which you have higher risk. For maternal mortality, what do you think the causes are for the other 50% of deaths? Homicide, suicide, drug overdose. And during COVID, those went up. Because women were home COVID. That's what went up. Only 5 of those additional deaths that occurred during the pandemic were attributed directly to COVID. All of the rest was a massive rise in those other folks. In fact, most maternal mortalities that happen in that year after birth have to do either with heart disease issue or with substance use, particularly now post-pandemic. Mental health is a crisis, mental health. And so focusing on what the media is telling you that's scary mom during childbirth, that's not where this is happening. We're not taking care of people. People after a few weeks after they have their baby, they disappear. 1 in 4 women is back 2 weeks after she has a baby in the United States. We're not taking care of people after that hospitalization. Sometimes people show up in the emergency room, maybe 6 weeks after you have a baby, 7 weeks after you have a baby, you don't feel well, someone takes their blood pressure, it goes really, really high, put you on blood pressure medication, but nobody puts that into context that you just had a baby. This is a maternal issue, and we're misdiagnosing. You see deaths happening there from cardiovascular disease because they didn't realize what the reason was, right? You can't treat everyone the same. We have to individualize that here. So we know that's what's happening in the Black community in particular. We're not really paying attention or listening or missing stuff. If you come in with healthcare trauma already, it gets even more difficult to try to explain what's wrong with you. So we're keenly aware of that, and we're focused on that as we kind of reinvent how we're going to be delivering healthcare. So here are some of those interesting key findings. These came from Blue Cross Blue Shield. A greater number of women are entering pregnancy with pre-existing conditions. Chronic disease is on the rise in the United States. We're seeing more people who are living their lives with chronic illnesses who may not even be aware that they have them. The number of women experiencing pregnancy complications and childbirth complications went up 31.5%. Again, cardiac disease is kind of leading that cause. Women with pregnancy complications are twice as likely to have childbirth complications, and the number of women diagnosed with postpartum depression has increased nearly 30%. Women are different consumers of healthcare than men. They actually spend more money than men do on healthcare. So these great consumers are making all these decisions, right? Do you think women are leading? We'll talk about that more. But overall, women pay $15.4 billion for more than men, right? 18% more than men annually out of pocket. And for all ages from 19 to 64, the average woman pays more about the average man at the same age. Even when excluding maternity leave. Maternity hours is about because people are like, oh, they have babies. Take that out, we're still spending more money. Okay? Women spend more per visit than men do. Yeah, sure. Okay, closer to my mouth. I am a midwife and I have a soothing voice. Is that better? Okay, and I'll stop turning my head. Okay. The values employer-sponsored coverage for women is actually less than for men, but we are spending a whole lot more. So who's leading women's health? Well, 80% of healthcare decisions made by women, only 13% of hospital CEOs in the country are women. So the majority are men, the majority come from a business side. And I will tell you, when I meet people in senior circles of healthcare, who are like, you are a midwife, how did you get to be a hospital CEO? And I'm like, you're an MBA, how can you be a hospital CEO and you haven't taken care of a patient? Like, so that usually ends the conversation because we all come to this from a different reason, and it's about intent, and it's about picking up those skills you didn't learn on your path on your journey. We all get them in a different way. But I do think I'm as far as I know, the only nurse midwife who's hospital CEO in the United States. It is an unusual pathway. Most come from a business side because healthcare in the United States is a business. Yes. But I'm here to tell you, you can pick that up on the way. Yes, you can. So 1 in 4 C-suite leaders is a woman. That means everybody else on the leadership team, so 3/4 is male. And only 1 in 20 of those is a woman of color. So of the 1 in 4, only 1 in 20 is a woman of color. My favorite statistic ever, there are more CEOs named John in the United States than there are female executives combined. Everybody remembers that guy John, like we just heard about Chad. John in healthcare leadership. Very few hospital CEOs have a clinical record. Does anybody know how many hospitals there are in the United States? 6,185, right? But how many of those have CEOs who've taken care of patients? Only 33.
Wow.
Yeah. Women want individualized care, but healthcare and healthcare regulation is designed to standardize care, make it the same for everybody, because that's how insurance companies reimburse, right? We think it needs to go this way, so this is what we're going to pay. So it's not very individualized. And we tend to remove choice and voice from the patient because it's kind of an a la carte design, like here's how it's supposed to go menu. So women are second up to be with us. This is from McKinsey & Company, this is from the Women report. This is the current Women in the Workplace report that you can just download it online. All of this data is in there, and it's very recent. And what McKinsey told us is that women are leaving leadership positions. Post-pandemic, women are leaving leadership positions. Last year, 2 million female leaders left their jobs, not just healthcare, in general. So while women really want to take charge and do stuff, they're walking away from traditional leadership roles. Important to know. But you can see here that the higher up you get, the fewer women are represented in the industry. This is what it looks like for women of color. So here we are. We know that Black women are more likely to die, but they're not represented at all on that stretch that's making decisions about okay? So you can see here, for women of color, that's that little aqua box on the right. That's a very tiny percentage, right? So this is that statistic on women leaving. You can see in 2021 we saw a spike. It started during the pandemic, it's still rising. It's not just women in leadership in the US, it's female politicians worldwide. Women are stepping down. Anybody know why? Childcare is one of those. It's because women take on additional leadership roles. They're not just coming in, running their company, they're the ones leading diversity and inclusion. They are the ones mentoring. They are the ones caring for their babies. They were the ones who had to stay home when the pandemic hit. They're doing it all. They're not just coming to work, checking the box of the day job and going home. They love doing all of these things and they do it. And at some point, you just tell yourself, I can't do all of this anymore. Because when the pandemic came on top of that, it really stretched us so thin that people said, I'm just going to start my own company with other people who think like I do, and we're going to do the same thing everybody else is doing, but we're going to do it our way. That's what we saw happening last year, which is very interesting. Can't wait to see what entrepreneurial stuff comes out of that the ladies are going to lead. Here's the current workforce for healthcare, for women's healthcare. There are only 23,000 obstetricians and gynecologists in the United States. And in about 30 years, there will be 22,000 OB/GYNs short. So we're not seeing as many OB/GYNs coming through school or coming out of residency. And I love interaction, so if you have, some thought of why do you think that is? You guys know why that is?
The insurance.
Yes, because it's a highly litigious profession, so you're really likely to get sued. And once you get sued as a physician, it's very hard to go on another medical staff, right? So if you want to move somewhere and you come in with either 2 lawsuits, it's going to get more and more difficult to be able to actually work somewhere else. So doctors tend to stay put in the same place, not move a whole lot. Yes, it's one thing. But people know this. You can Google it, say what's most likely, especially to get sued in healthcare, OB pops to the top. Now, it's not that more bad stuff happens in OB. It's that there's a lot of empathy when moms and babies are involved. So those lawsuits are often settled or won very easily as opposed to a knee replacement case. That is the reality. There's a lot of emotion because it's a tragic, horrific thing. And so we tend to see, a lot of empathy from juries, a lot of empathy from everybody involved, including the people who were part of it. So they are often won, and that's the difference. The other reason is that these are long hours, right? 24 hours a day, you need to be ready to come in and catch a baby and save a life. So it's very different than a job that has a little bit more work-life balance to it. It was always very heavily male-dominated. We're now seeing it become more female-dominated. We're going to talk about that in a minute as well. More than half of OB/GYNs men, women make up 85% of residents today. So we're going to see a natural shift to more women leading OB/GYN from the clinical side, which will make a difference as well. OBs are starting to retire at a younger age. It used to be age 68. Now we're seeing about age 53, 54. They're starting to get tired of doing OB and they switch to GYN surgery. So we're seeing younger people come in. And what physicians tell me, I'm a hiker, I like to go hiking, so I'll drag a doctor with me, see what they're made of. And I'll take female OB/GYNs with me hiking, and what they say is, I get so angry, particularly the younger ones, because I'm just kind of colored with this brush of being coercive, listen to me and all that. And that's the previous generation, right? Everybody comes in worried that I'm going to be that doctor, and it's exhausting having to keep people at ease and constantly miss. I'm not like that. So we're seeing that younger generation really compassionate. They went into it for a different reason. They went into it despite all the challenges of the profession. So we're seeing kind of a different type of OB/GYN emerging now in the last 5 to 10 years. So that is going to kind of organically switch the way that we're listening to women and caring for women over time. They live in this world with you. They are having babies. They are experiencing their healthcare along with you. So they have a really good understanding of how you feel when you're getting your care as well. There are only 13,524 certified nurse-midwives in the United States. Well, that's not going to help fill that gap a whole lot. By 2030, we will be 13 million nurses short in the United States. We saw an exodus of nurses during the pandemic. Many who were end of career did not want to do this level of stress anymore. Work is hard, so we are having to work smarter and do different things, working with technology, AI, creating new positions that help nurses so they can just focus on that thing that they're super skilled at. So that's going to change healthcare as well. But what we know is that in nations with really good outcomes, midwives actually outnumber physicians 3 to 1. And why do you think that is?
Is it cost?
Part of it's cost, so you can have a bigger workforce. There are more midwives in those nations. Yeah.
Is it because midwives have more autonomy but physicians has a birth experience?
Well, I think physicians and midwives both have the autonomy to do so, but midwives see birth as a normal life process, so they kind of focus on that. For a midwife, you're normal unless proven otherwise. For a physician, you're potentially high risk until proven normal, right? It's a bit of a flip in the thinking. That's what you want. That's how they're trained. They're surgeons. They're experts in pathology. But it's also just a normal part of their culture, right? If you go into other nations and you ask people, where do you go to have your baby? They don't want to go to the midwife. The doctor is there for those things midwives don't. In the United States, certified nurse midwives have the same scope as physicians, but they don't take care of critical illnesses, right? They don't do surgery and they don't take care of critical illnesses. But birth is overwhelmingly a natural process and a normal life process. So they're a very valuable addition to the workforce. They work in hospitals, they can prescribe their drugs, they can do all the same things that a physician can do, but they focus on normal pregnancies. They can't take care of high-risk pregnancies, And if they need collaboration or support in some way, like if you have a really unusual clotting disorder or something like that, they work side by side with physicians on that really complex medical. Okay? But it's normalized in other nations. And because midwives focus on just not doing stuff to people and then you have a baby, they go, you're fine, go home. Come back in 3 days. You don't need everybody today, right? Let nature take its course on those things. That's what we're seeing better outcomes. We're doing less stuff. All right, cost of women's health. Obstetric care tends to, in the United States, take place in hospitals. More than 95% of babies are born in a hospital in America. The average birth costs $14,000. But every labor and delivery unit is set up like an ICU, right? Because we can't have maternal mortality or neonatal mortality, so we throw everything at it. You are going to have doctors, nurses, OB techs, support people, anesthesiologists, the people who set up tables, people who come and rescue you. So we pay for every birth, very expensive setup, just in case something really bad happens. And that's a good thing, right? We want to make sure that we can intervene and move that well, but it makes birth a very expensive thing for our hospital to do. Women's surgical procedures are sometimes reimbursed at a lower rate than men's. It's getting a whole lot better, but for many years there was a thought that it's just harder to do that same procedure on a man than it is a woman. Don't ask me and where that came from, but that was the thought. Many hospitals have closed their OB units because the cost of care, shortage and cost of providers is not sustainable, and this leaves care deserts in the United States. Areas that have absolutely nowhere to go to have a baby. Once you get past 30 minutes of driving, then you're considered a care desert. 2.2 million women live in care deserts in the United States. This is from the March of Dimes. You can see where those care deserts are. The bright pink and all the pink are care deserts. Okay. So you can see there are some areas of the country where there's full access to maternity care. That's the gray. Everywhere else, you have big gaps in care. And Virginia is no exception. I've worked in areas in Virginia where it's 100 miles from a hospital, about 2 babies taken care of. And that's not that far from here. You'd be surprised. 55% of countries lack a single certified nurse-midwife, and almost half of the counties lack a single OB/GYN. It's not enough. So here on the right, these are the statistics I talked about earlier around maternal mortality in the state of Virginia. That's straight from the triennial report from the state. So you can see 51% were natural causes, and then you can see accidental, which is most of those are substance use things, drug overdoses, homicide, suicide, and then undetermined, right? If we've got somebody down in a car, they tree probably a car accident. That's what we need to think about. Like, how do we address the problems and the issues and the things we really want to avoid? Technology is a big one. I talk about this all the time. You've heard me speak before, you know this is my thing. Now, everybody in this room probably knows, either from TV or personal experience, how we monitor patients when they're you've got the belt, you've got those 2 big things sitting on you, you can't remove that anymore now. Why don't we have better technology for that? Like, how long is it going to take? So we keep designing our birth experience and everything we do with moms around the stuff we have. Why not ask for something to be different that helps us, walk around and do all the stuff we do? I worked with GE on a new monitor. It is now available in the United States. It's actually a sticker. It sits on your belly. Now you can walk around. It's not great yet. You can't lay in a tub with it. It's going to kind of soak up. It's a sticker. But it's getting a little better. People are starting to think differently about this, right? Those things they put on your belly, one of them is just a pressure button, right? Your belly moves, it registers it. So you get a tiny contraction, and they look like a mountain. Everybody goes, oh, I'm having a big contraction. It's just a push button. I could stand in the hallway. We used to do that for I'm a scared doctor. You squeeze all the buttons and they walk in, think there are 20 people in labor. You can make that thing do it. It's not real high-tech. It's not high-tech at all. The other way to find out how strong your contractions are internal monitors. Now you're laying there, you've got these things sticking out inside you. It's uncomfortable, it's painful, it causes infection. Why are we thinking of something better to do? That just doesn't make any sense to me. Surely you could put people on the moon and figure out how to monitor mom and baby without doing all of this stuff to make us very uncomfortable. And not necessarily have great outcomes, right? So we're doing it. Yeah, we're doing it. So that's coming, right? But I want everybody in this room to think a little bit differently about it. Just start questioning, why are we doing it the way we're doing it? You don't have to. You can really be innovative around that. Pressure to avoid adverse outcomes, right? Nobody wants a maternal mortality or a neonatal mortality, so we're throwing everything at it to make it work insanely expensive. Workforce, we talked about that. People's expectations. People come in completely different expectations. Everybody has a different idea of how they want to be cared for. But what are we doing in healthcare so far? We practice the golden rule. Do unto others as you would have one done unto yourself. Well, how does that work? You have a totally different idea about what care should be than your patient. So I tell everybody in my hospital, we're practicing the platinum rule. Platinum rule, do unto others as they want done unto them. So we sit down and we figure out what's important to people. It takes a whole 5 extra minutes for us to really ascertain that during hospital admission. To really flip that narrative around. And almost always, when we do that, we find out really interesting things about folks, and we can actually really help them have the experience that they want. It just helps to know what's important to them. But in the United States, more than 80% of women are super happy with their birth experience. And is that because they got exactly what they were expecting? We're not really sure what goes into that, right? You spend 9 months with somebody who kind of tells you how it's all going to go, and then it goes the way they said it was going to go, and does that mean that you're happy? This is really what you wanted. It was what we came to expect, or what society expected, what your friends thought you should have. But 80% of women say I was really happy with that. The other 20% are extremely unhappy. That's what happened. We hear about coercion, we hear about, I wasn't heard. We hear about something horrible happened to me because somebody did not listen to me. Something was really important to me and nobody made an effort to do that for me. So we know that there's work to do. Disparities, big problem, not just in the United States, but in the state of Virginia. We're focused on that. Impact of chronic disease, substance use disorder, mental health, and then NED specialization. Many physicians now are going into specialty care. So what used to be your community doc who sewed up your knee and then ran to the hospital and catch a baby, or your house, or treated your headache and do all those things, that doc does not exist anymore. Right? There are family practice docs, there are OBGYNs, but what we're seeing now is even that broad spectrum of OBGYNs is going by the wayside. We're seeing people specializing in certain gynecologic surgeries and no longer practicing obstetrics. We're seeing people only do OB, but they're not great at GYN surgery. This is not what they like to do. So that specialization means that if I run a hospital, I might have hired 3 doctors now for what used to be that one doctor, making the shortage even more pronounced for us. All right, don't worry, folks. There's a solution coming. We'll cheer you up in a minute. So, different types of care models. One is OBGYNs. The other is OBGYNs working with certified nurse-midwives. You'd be surprised how few hospitals in the United States are doing this. There's still a big misunderstanding about how this all going to work. But I will remind you that not that long ago, we only had anesthesiologist doctors, and they didn't want any CRNAs. And now CRNAs are everywhere, doctors can't live without it. It's only because you've not done that, and you need to make the effort to go work together. So it's about normalizing and working together. OB hospitalist. This has gotten a bad rep, and it's probably one of the best things to ever happen to OBGYN. An OB hospitalist is a physician who just works in the hospital. They work 24 hours, 12 or 24-hour shift. They're there for anything that rolls in the door, and they can take care of it. They can do surgery, they can deliver your baby. They just didn't do your prenatal care. And so people have this thing in their head of the person who took care of me in pregnancy has to also be the person to catch my baby because I think that that's how it's going to go better. We're actually learning is that the person who's been taking care of you all that time may have been up for a long time, working really hard, and may not be as patient waiting with you for a more normal birth experience. This person's going home. They don't have a golf course to go to. They don't have to, that's the old joke, right? They don't have to go to golf course. I don't know any doctors who golf, actually, which is kind of interesting. That's not what it is, right? It's that busyness, it's the perception that if you took care of me during pregnancy, you're going to give me a great birth. We know that's not true. In hospitals where the care is done by OB hospitalists who are only there just to take care of women in labor, and that's what they love to do, it's what they're good at, they're not on the clock, they have a whole team that they work with every day, the outcomes are actually a little bit better. Out of hospital birth is another care model, so birth centers or home birth. We saw that climb during the pandemic because people they want to have their family with them, or they were afraid of going to the hospital and getting COVID. But in the whole nation, out of those 3.6 million births, there were only 50,000 home births, even at its highest, which was in 2021. And then collaborative care models. Put all of these people together in a collaborative team and learn from each other and work together to optimize the care. What I like to call it is the fill in the basket, putting everything in it, and you only take out what that patient really needs, right? To get the lowest intervention possible for her. So here's the goal. We want minimal intervention. We're looking for cesarean reduction. Anybody in the room tell me what the national cesarean rate is?
30%.
So a little bit higher even. So more than 1 in 3 women will have a C-section. World Health Organization sets the goal of 15%. CMS sets the goal, and Healthy People sets the goal for less than 23.6% of first-time healthy mothers with head-down baby should have cesarean section. So that's the goal, 23.6%, but it's hovering around 32% in the United States. If you're a first-time mom, snowful normal, baby's head down, you're full term, everything about you is good, that section rate should be below 23.6%, and it's higher. So we want to avoid an unnecessary cesarean. Yes?
That's a good question. So with that statistic, do you have any knowledge with regard to how that percentage does or does not increase when you look at women of color versus non-women of color having a cesarean?
That one actually doesn't change a whole lot. What we do see is that if people are in rural areas where the doctor does not know you, and there's not a hospitalist, and you show up, right? You're an immigrant. You're not in the census. You don't have a social security number. You don't have insurance. You don't have a connection. We see people doing cesarean sections more quickly. And a lot of that is, I don't know this person. Why am I sitting around for 26 hours, right? So we know that. We see that more in people who don't have great access to care, great access to physicians. There are some other reasons too, but that is not one of the places that we're seeing a huge disparity. There are other cultural things that we all have in common as women that kind of play into that, but that's not usually it. Sustainable workforce, we need OBs, nurse midwives, we need more nurses, we need more anesthesia providers. We want to focus on autonomy and birth options for our patients. We have to fill our basket with all of the stuff that you could possibly think of that somebody might want. Right now, we're all just kind of doing the same thing because what we talked about earlier, we're trying to standardize, right? Hospitals tend to think like this is what we should do, so we're just going to put this in the basket. No, we want to fill it up so that on an individualized care basis, you can come in and fill out what you want. What you will see is an increase in better outcomes because people come in and say, this is important to me. You know, I want to be able to eat something when I'm in labor, right? I really want to wear my own clothes. I want to be able to walk around and have a monitor where I can be mobile or get in the water. Those are the types of things we're filling the basket with so that, you know, people are laboring as normally as possible. Nature is not broken. It knows how to have a baby. Your baby knows how to be born. So normalizing that while safeguarding at the same time, that's what I mean by that. Autonomy for providers, meaning that everybody should practice to the fullest of their scope. What you don't want is somebody working in a hospital who's told you can't do any of these things, you can only do these things. You want everybody to be able to do everything for you in the hospital. That's how you create good collaborative care teams. So expanding scope, or what we like to call delineation of privileges, we want to make sure we can all do everything we possibly can to step in and help you. Improved technology, we talked about the monitors. This is what the OB looks like. It's the sticker on your belly that is water resistant. You can walk around with it. Now here's the interesting thing. Those belts that you see in the hospital, you know, one of them's a push button. What's the other one do? Right? Listens to your baby's heartbeat. But how does it work? Anybody know? It's ultrasound. It's just ultrasound. It bounces sound, and in return, you know, it picks up that baby's heartbeat. But the bigger you are, the more adipose tissue you have, the harder it is for ultrasound to go through that. And so what happens is that when somebody's BMI starts to go up a bit, and 53% of the pregnant women come in with a very high BMI, we're seeing that increasing in the United States as well, and monitors are going to work. If you've got a little extra on your belly, it's not going to work. So now we're looking at internal monitors and all this other stuff, trying to figure out what's going on with your baby. Again, technology is not good. This monitor looks like electricity. So it picks it, you know when you get an EKG and it reads the, you know, the electricity that your heart takes out? That's what this does. So you put it on, you give it a minute, it figures out mom's heartbeat electricity, baby's heartbeat electricity, and the more adipose tissue you have, the better electricity travels. So now, You can walk around. Now there's technology that allows you to do everything that you wanted to do, and it doesn't matter how big you are. You get the same chances as everybody else because our equipment supports you. That's the problem. Women of size don't get the same treatment because our equipment isn't made for them. Okay? So we're thinking very heavily around all of the technology that we need to work on to take care of every woman who walks into our facilities, to give her the optimal chance and the autonomy to have the birth that she wants while safeguarding her life and her baby's life. Improved reimbursement, right? We want to make sure that as the cost goes up for all hospitals, that all equalizes out, right? Hospitals have to pay a lot more in labor costs and other things. We want to make sure that hospitals don't need to close down just because they're not getting paid for anything whatsoever. So that is on the table. But the other part of that, we need to provide cheaper care, right? We need to pass cost savings on to our patients. We want to make sure they're only using what you need, not what the most high-risk patient would need. It's not doesn't make any sense if you roll in at 8 centimeters, have a baby in an hour that you would be, charged, $14,000 for a birth, or you can utilize all of those things just because we have to have it in place, right? So a lot of discussion on how do you do that? How do you create a low intervention birth environment while making sure we have no maternal neonatal mortalities? This is our homework. This is what we need to figure out together. Focus service lines. In many health systems, women's health is not one of those service lines that has a topic expert at the helm. Kind of worked out in each hospital, physicians at the table thinking, hey, this is what we should be doing. So there's a lot more focus on making sure there are leaders who are topic experts who understand all of these nuances to help direct the care for hospitals so that we don't steer ourselves in the wrong direction or end up, with something that isn't working out for the community and for our hospitals. So focus service lines. Reduction of maternal mortality and neonatal mortality, we know what those causes are. We know what those are inside the hospital during the admission for labor and birth. So that's policy revision. It's making sure you have the tools. It's making sure you have blood supplies, making sure you have everything you need to take care of that patient, even in community hospitals. Access to prenatal care. People always think it's easy to access prenatal care. It really isn't. Many physicians are kind of picky about who they take or which insurance they take. Many women can't find a nurse midwife, and there's only 13,000. Probably about 25% of those are not practicing, right? People can't get there. They don't have transportation. The bus line doesn't go to the place they want to go. Doctor doesn't deliver at the hospital where they want to deliver. But you can go on and on. Or people are scared. They really don't want to go. Or they're worried about being chastised, or they've had a bad experience. So there are many women who hop from ER to ER to ER for their care. Right? We don't want to engage in care because we've not made that a very pleasant or easy experience potentially over the years. So access to care is not simple. We need to look at that in a different way. Postpartum care to include mental health support. We did a survey very recently on a large number of our Sentara patients in Norfolk and Virginia Beach. And from year to year, we just do a poll, like what's important to you? What are you thinking about when you have a baby? And the last one that we did had a 20% jump in the need for mental health resources for new mothers. So there's a heavy focus on that. Sentara does that in partnership with the health plans, right? We all work together. And so now we're making sure that we're sending people to check on you for those 365 days after you have a baby. It's the whole management. Right? There's a lot of discussion around what should be covered by Medicaid, as you know. So we're all intently looking at what's going to come forward from that because most young women have a baby are on Medicaid. So we want to know, where that's going to go in the future. Yes?
So if we're talking about what Medicaid covers, I'm a birth doula, and I've come from Rhode Island, where it's first state for insurance actually covers birth doula care, and birth doulas can reduce a lot of these issues in conjunction with nurse midwives and doctors and things like that.
I was a doula. I was a doula for many years. Right?
Yeah. And what is the hospital perspective? Because I think sometimes
From the next slide.
What?
From the next slide. Oh, yeah.
Okay.
There you are. There you are. All right. So, great segue, right, to kind of like where are we going to go? Yes, every state is completely different. Now, not everybody understands what doulas do or what role they play. Doulas are perceived differently. They kind of culturally develop in the region, right? Depends on how hospitable the environment is. including other members in the birth team. So kudos to what you do, and I know how important you are. I'm going to talk about here why doulas matter in the birth environment. So what we want is we want low-cost care, because that helps everybody. We want high-touch care. We want to make sure that we are focused on that. I just don't have time warning, so I'm going to speed it up a little bit, okay? Women leading women, right? If women are making 80% of decisions, we want to make sure there are women involved in decision-making in healthcare systems. Access to care for high-risk patients, we want to make sure it's there for folks who really need it, but not everybody needs it. Collaborative practice models, put everybody together, make sure that we have everybody working together on their specialties so we can give women what they're looking for. Full scope practice. We want to go back to primary care physicians potentially being able to deliver babies again. They want to, it just kind of went out to the wayside over the years. We're trying to pull that back in. So that particularly in rural areas, your doctor has a full skill set and they can still deliver a baby. And that's back on the table. Doulas. The doula is a support person for somebody who's pregnant, for somebody who's in labor and postpartum. This is somebody who truly understands all the nuances of pregnancy and birth, and can help guide people, not just, hey, this is a great thing to learn to have a baby, but really help translate, right? The language of birth, the interaction that's difficult, how to get your voice in healthcare, and provides a lot of emotional and physical support and comfort for somebody along the way. During the pandemic, doulas were the saviors of the OB/GYN because they were in homes and they were the translators to the healthcare system. The goal for healthcare systems is to make sure that doulas are welcome, that everybody gets to choose who they want with them during their birth. Doulas are not healthcare providers, they don't want to be healthcare providers. They feel an obligation to make sure that somebody has the best possible safest experience in their care and celebrate with them when they have their baby. And then make sure that they feel supported after that. All of the gaps in the healthcare system, doulas pick up for moms and babies. Community healthcare and pre-pregnancy care. Unwanted pregnancy prevention. I want to make sure people have access to that level of care as well. We want to improve childcare. Somebody said that earlier. Great point. It's really hard to go out and do all these things if nobody's there to watch your baby. And when we closed the doors during the pandemic to children at visits, people stopped coming to their prenatal care because they have no way to take their children. So these are things that we think about for healthcare as well. And then protected postpartum recovery. We want to make sure people get a little time off. One in 4 women return to work in 2 weeks, and then it's just way too soon. Physically, emotionally, it's not good for mom or for baby. And that is my presentation.
I noticed that in your statistics, one of the things that it lacked was age group.
Yes, it is higher risk to have your baby when you're over 85.
That's all. I'm just talking about for taking statistics in general.
Yes.
To show that age group that is most represented. So that in the statistics where you showed about the mortality, how the age range of those people would have been important in terms of prevention and providing services, etc. I'm in education.
Yeah.
And so I see it at a lot younger
Yes.
age group. And so a lot of the risk factors that comes along with having a child at a young age includes the lack of education. It includes the services, child care services, and things like that. Transportation, because you're not old enough to drive, or you don't have the finance to have your own car.
100% agree with you. I could do a 3-hour presentation just on all of those things that contribute to adverse outcomes, not just during pregnancy and postpartum, but just for life, right? The really good thing is that the state of Virginia Maternal Mortality Review Board does have all of that. This is publicly available to you. You can go and just Google Maternal Mortality Review Virginia, and that triannual report comes up and it breaks that down. It breaks it down by age, by education, by demographic. It's got great graphs in it. So you can actually puzzle that out. It's incredibly well done. And the narrative at the end of that addresses all of the things that you just said. But what we know from the mortality component it actually sharply increases over age 35. That is where the majority of those mortalities are. Now, it's not because birth is more risky when you're older. It's because they have lived with chronic disease longer. Or with other issues like racism or bad experiences or, substance, all of those things that contribute. There's a concept called weathering. How many of you know this word? Weathering. I'm surprised so few of you know it. I will take a little bit of time. Weathering. Picture a shed on a beach. In heavy wind, right? What happens to it? It starts to kind of crumble and the paint goes off and the roof goes off a bit. That's what happens to people after prolonged stress in their lives. Stress from, adversity, from having to work harder than other people, from racism. All of these things compound in this concept of weathering. You just weather down. And so when that happens to you for a really long period of time and you present for healthcare, you're at a disadvantage from somebody who didn't have that level of weathering. So if I can leave you one thing today, that's an important concept to understand. I know.
We're gonna have to wrap up.
Okay,
I'm sorry.
All right, I'm easy to find. So if you guys have more questions, feel free to reach out. Thank you.